Hello, my name is Brendan. I'm a medical student at the University of Hawaii Medical School. I'm here with Dr. Ezekowitz, who was the principal investigator of the sodium HF trial that was just a late-breaking clinical trial at the ACC 2022 meeting here in DC. Dr. Ezekowitz.
Hi, thanks, Brendan, and thanks for having me on this cast. This is exciting times for ACC and fellows in training especially. So maybe I'll give a bit of a summary of the clinical trial first, and then we can go from there. Overall, we did a large clinical trial, about over 800 patients, testing whether or not reducing dietary sodium would change the clinical outcomes for patients with ambulatory heart failure. We started with a really good clinical question, which is, does it matter to give dietary recommendations on reducing dietary salt? And that kind of germinated from lots of practice. When we did the clinical trial, we did a typical 1-to-1 randomization of lowering sodium, dietary sodium intake, which is less than 1,500 milligrams a day of dietary sodium, versus usual care. Usual care is often a mixture of different recommendations a patient may get in clinical practice from any clinician, a physician, nurse, dietitian, you name it. And it tends to be around 2,400 milligrams or so for the average patient with heart failure in North America, and a bit higher across different regions. We did the clinical trial overall, and our primary endpoint was 12-month all-cause mortality, cardiovascular hospitalizations, or cardiovascular ER visits. And we had secondary outcomes of KCCQ, quality of life, NYJ class, and 6-minute walk test. The primary outcome of the trial was neutral overall. The hazard ratio was 0.89, broad confidence intervals. We had to look at this carefully because we had to stop the trial a little bit earlier than we had anticipated for a number of different reasons. But nevertheless, that was our primary outcome, and then looked at our secondary outcomes. Important secondary outcomes for us were quality of life, which did show a very meaningful difference of about 3 points or so in the KCCQ overall summary score, clinical summary score, and physical limitation score, as well as the improvement on NYJ class, which is assessed by clinicians, so corroborated that evidence on the other side of the patient-clinician interface. There was no difference statistically in the 6-minute walk test overall over 12 months. So overall, that's our clinical trial in a nutshell.
Great, yeah, it's super interesting. And I think what's really interesting is the fact that just kind of simple dietary considerations that we kind of sometimes overlook, even my own diet, can have kind of such a meaningful effect. I guess my first question is how you use diet in your current clinical practice. What kind of made you look at this particular topic?
Yeah, it's a really good question, Brendan, is why study something like this? I mean, why not just recommend it for all patients? And that's what really struck me as to why we should study it is, I'm spending a lot of time talking to my patients about this thing called diet, and is it meaningful? Does it change outcomes? Can they make these changes? Should we be recommending? All these questions that come up, and what you realize very quickly when you do a literature search around this and say, oh, maybe our guidance isn't as well supported as we thought so. So my general practice shifted from making a strong recommendation to do these things, because I was trained that way, to really question that and then design a clinical trial, which it takes it a whole new level of challenges ahead. Now my practice is much more thoughtful for a patient's individual circumstance, maybe a bit more fewer questions around the small dietary elements, but sticking to the big items like, are they eating 2 bags of chips a day? Do they have a big gulp in the front seat when they're driving? All those things that maybe have a bigger difference, and trying to think about their diet as part of their health. So a health strategy rather than an individual, often a finger-pointing exercise, which isn't great for patients and isn't great for us to do.
Yeah, I think that's really interesting. I guess a follow-up question then is, you had a multinational study, New Zealand, Canada, where you're from, a lot of places. But we're at the American College of Cardiology. A lot of people in America have a very high sodium diet, maybe kind of even above your control group. And so, do you have any thoughts about how your findings might generalize to, super high sodium diet families?
Yeah, very, very important question. Generalizability of a trial after you're done that is beyond your old local environment. We had 6 countries, and some of those countries have a much higher sodium intake than, say, Canada does. But even within Canada, there's a gradient from west to east for higher sodium. So even within regions of a country, you can see gradients. You know, it's a little cautious to say this is directly applicable to the U.S. Our sites in, for example, Mexico City and in Colombia also eat very high salt. And so in general, I think they're much more reflective of some of the southern U.S. Patients that might be exposed to a higher sodium. But in, you know, as you go up a gradient in the U.S., the further north you go, the less salt they eat in general. So I think, you know, it is reflective of the U.S. population, and broadly speaking. We have patients who are eating well over 3 grams of sodium a day, and we have patients eating 2 grams of sodium a day. So I think we have a generalizable result. The question is there another trial we'd like to do where people are only eating a very high amount of salt? And it's a different type of trial we haven't done yet.
Next one, I guess, then. Great. So another question kind of more specifically about trial design is, I noticed you had a fairly high compliance rate, actually. Whereas dietary studies, at least from my limited knowledge, often they don't stick with the diet, and we only had a 1-year kind of time frame. So do you have any thoughts about kind of if these patients can stick long term? I know you only looked at outcomes for 1 year, but it may be difficult to find mortality differences in just that 1 year, and you even stopped the trial early from efficacy and for COVID. So kind of just thoughts about the time frame of the study in general.
Yeah, so a nice question to think through, and we actually have designed a 24-month and 5-year, so 2- and 5-year follow-up of these patients. So we do have that planned. Of course, we have to be patient, which is really hard in the clinical trial world, to be patient. But that's really our next goal, is to follow those patients forward as we go. Now, from the adherence question, which is kind of the Achilles heel for most dietary trials, we thought about this very much up front in a different way. We've recognized we're not doing something like the keto diet or the Atkins diet. What we're trying to do is just modify a single element in the diet, which is very challenging. So we created really a menu-based system. So a patient in their local environment would be able to shop for, eat, or make those changes without altering anything else. So the menus are very broad and comprehensive, and people could really eat what they want, just make better choices along the way. So the way we got adherence was, first of all, designing that up front with our dietitians and patients involved. And then secondly, we had periodic phone calls with the patients to reinforce, pick up on where they were having some gaps. The 3-day food records, which is both a measure of things like dietary sodium, calories, etc., was also a way to counsel patients, because then you could see what they're eating and saying, oh, that bag of chips you had there, those capers you had there, that's why you're still over the mark. So we had adherence in many different layers. It's never one thing. So I challenge people to look at their own diet and say, how would I have done this trial if I'd been a participant, and what would have made a difference for me being able to stick to it?
Great. Well, I think we're coming up to time. So everyone should read your preprint paper. Just came out in Lancet, I believe yesterday. And do you have anything, last parting thoughts?
Yeah, well, look, I think the key is we have to study everything, and anytime you see a recommendation that isn't supported by good science or data, you need to ask the question is, should we study this, and how do I study this? And really discuss it and just get into things like clinical trials and clinical research to further advance our patients' care.
All right, thank you very much.
Nicely done. This is very well done. So the next step is just a 30 to 60 second segment. So you'll start off with, this will be like a really quick introduction, less than the other ones. So, hi, I'm Brendan Seto, and you just hand it over. You can say can you tell us more about this specific trial? Yeah. You'll look, this time you'll look directly at the camera for the 30 to 60 seconds. Then you can hand the mic back to him, and then you'll finish off with thanks for joining us. For more videos like this, please visit our YouTube channel at Fits on the Go.
Fits on the Go?
Fits on the Go, yeah. Or you can say Fits on the Go YouTube channel, and then we'll actually post a slide with a link and everything at the end of it.
Okay, that's good.
All right.
All right, thank you very much.
And we're still rolling, so you can go.
Oh yeah, great. All right. Hi, my name is Brendan Seto. I am a medical student at University of Hawaii Medical School, and we're here to talk about the Sodium HF trial.
Thanks, Brendan. So a quick trial summary. We did the Sodium HF trial, a 6-country, 26-site clinical trial of our over 800 patients where we'd lowered dietary sodium in the intervention arm to less than 1,500 milligrams a day compared to usual care. For the overall primary outcome of cardiovascular hospitalization, cardiovascular ER visits, and all-cause mortality, we did not show a difference statistically, and the hazard ratio was about 0.89. Our secondary outcomes, the quality of life by KCCQ, were significant in favor of a low-sodium diet, and our NYHA class secondary endpoint was also in favor of a low-sodium diet.
All right. Thank you for giving your time to us. And if you would like more content like this, please follow FITS on the Go, either on YouTube or Twitter or all of your social media. Thank you very much.